All right, Magda, am I good to go?
You're good to go.
All right, so thanks for joining us, Christopher. We are trying to get some education out to high school students, to students that do have a background or wish to go into some type of health sciences. So thanks for joining us today. We are doing this virtually, mainly as the result of COVID and just being able to get to more people at once. So thanks for Magda for having me on. My name's Dr. Patrick Galvin. I'm a physical therapist. I'm also the manager of the Outpatient Rehab Services at Lutheran General Hospital. I'm going to be talking about our rehabilitation services that include physical therapy, occupational therapy, and speech therapy. And trying to advance this. There we go. All right, so I'm going to be presenting. We are having this recorded as well, and there's going to be some links to the YouTube channel. We'll have a couple of opportunities for some questions and answers. Christopher, if you have anything that you want to speak to, we'll continue to admit anybody else onto the call. So let's go forward. What is rehab? So rehab is a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in interaction with their environment. So we help people of all ages. We help people get better, get back to their regular day, get back to their regular lives. Anybody can need rehabilitation. It doesn't mean it's for the elderly. It doesn't mean it's for the old. It's not just for the sports athletes. It's not just for people who have sports injuries. It's literally anybody and everybody could come to rehabilitation. We want to help people increase their independence. We want to be able to get them back to their education or their work or recreation or anything that might be meaningful to them. To me, something that might be meaningful is lifting up my 15-month-old daughter. To somebody else, it may be being able to lift snow to make sure that they can clear the path to be able to walk to their car in the morning. So it really can be anybody and everybody. It isn't just people with disabilities, isn't people just with impairments. Anybody can become a patient. I mean, we've seen what the ice was a couple of weeks ago. A slip and fall on the ice can change your life, alter your life, and hopefully only for a short period of time. Sometimes injuries or dysfunction can happen and last longer periods of time. So there's quite I'd say the array of patients and individuals that we see in rehabilitation. In rehabilitation, we go through patient-centered care. And what that means is the patient is at the center of every single decision-making process that occurs. Every individual has something that they desire to get back to. So it starts first with person first language. So when I do talk about patient who has an ACL injury or a patient that has a stroke, we want to make sure to put that patient first and foremost, even in the verbal communication. We don't refer to people as ACLs. We don't refer to people as strokes. They do, potentially have an ACL injury. They have maybe had a stroke, but they are still a person. And keeping that first and foremost is really what we do as clinicians. Whether you're a hospitalist, a physician, or somebody working behind the scenes, in healthcare, patient-centered care is what we're all striving for, especially at Advocate Lutheran General Hospital. The provider is there to serve the patient. So we want to make sure to relate any intervention back to that specific individual. For instance, if I'm a carpenter, I have to be kneeling in low places to be able to hammer and construct. I want to make sure that I'm putting my patient into those positions. If my patient doesn't have to do that, there's really no reason to put them in those positions during their interventions. There's no really reason to say, hey, you have to be able to kneel. For instance, if I had a 80-year-old patient and she never had to kneel once in her life, in her daily life for what she does right now, and all she wants to have to do is get out of bed, stand up, walk to the bathroom, walk back to the kitchen, and she doesn't have to kneel, that's not something we're going to be spending our time on. Or vice versa, if it's a collegiate athlete that has to play volleyball, we're not going to be spending time kneeling necessarily. It's going to be more about the plyometric jumping, agility, going side to side, quick bursts of energy. That's what we're going to be working on. So not anyone can walk in with the same type of diagnosis or the same type of injury, but we're going to make sure that we service them as the individual based on their needs and what their desires are. So one of the disciplines that are in our outpatient rehab services and just rehab services in general is physical therapy. They're the movement experts who improve quality of life through prescribed exercise, hands-on care, and patient education. And similar to a physician who can prescribe medication, our medication is our exercise or our movement. It says patient education. Some of the biggest things that we do have to do with patient education, making sure that we're getting the knowledge that we have to the patient right off the bat. We don't want to be the experts and say, I'm going to hold this back from you. I'm not going to let you know about this as the patient. I'll let you know at some other point in the future. That's not how we work. We really want to make sure right off the get-go, if you are a brain surgeon or if you are the person who cleans up the lunch trays in the lunchroom, we want to make sure that we give you as much education as possible. And we try to shape it to each individual. Obviously, those two individuals that I described probably have different levels of understanding in the medical world. So we want to make sure just to kind of say, hey, this is what we're doing. This is what I'm talking to you about. Does that make sense? Or how can I tailor it to something that you would understand or that you work with on a consistent basis? So we diagnose and treat individuals of all ages, from newborns to people at the end of life. Believe it or not, newborns can go through physical therapy. They have something called torticollis if their neck is shortened when they're born. There's different types of hip disabilities that if you're born breech, you might have to have physical therapy. So again, it spans throughout the lifespan of individuals that will need physical therapy. And what we do is examine each person and develop a specific treatment plan individualized to that specific patient, whether it's reducing pain, restoring function, or preventing disability. That is what a physical therapist does. Now, when it comes to occupational therapy, there's definitely some overlap between physical therapy and occupational therapy in the sense that we want to work on patients and getting them back to their specific occupations or their specific job or their specific activity. Occupational therapy specifically works to get people across their lifespan to do things they want to do and need to do through the therapeutic use of daily activities or occupations. So what I would say is occupational therapy, I like a way an occupational therapist described it to me when I was in school for physical therapy. It's what's the difference between physical therapy and occupational therapy? If somebody is injured, the physical therapist is going to help that person get to the clinic. They're going to do the work with the motor planning, with the walking, to be able to get them into the clinic to work with the occupational therapist. The occupational therapist is then going to make sure that they're able to dress themselves, bathe themselves, get to the washroom, make sure to do more of those occupational or activities of daily living tasks that are going to get you into your physical therapy or occupational therapy. So common occupational therapy interventions include helping children with disabilities to participate fully in schools and social situations, or recovering from an injury to regain skills, providing supports for older adults experience physical and cognitive changes. One of the things that occupational therapists do is really embark on some of the cognition that's required, so that planning, whereas a physical therapist may say, okay, to be able to take a step, you have to be able to activate your quadricep muscle, and you're going to have to be able to place your foot in a certain position. The occupational therapist is going to make sure that you're able to adapt to the environment. They're going to make sure that you can make those decisions in a sequence that makes sense. It doesn't make sense if I want to go out into the snow for me to first put on my jacket. They're going to make sure that I put on my socks. They're going to make sure that I get on my pants, then my shoes, then my jacket, then my hat. So really helping with that cognition that we don't think about because we don't have that specific disability or impairment. So that is a big piece of occupational therapy as well. And then speech therapy. We have our speech and language pathologists that work to prevent, assess, diagnose, and treat speech, language, social communication, cognitive communication, and swallowing disorders within children and adults. Speech disorders can occur in a patient when they have difficulty producing speech sounds correctly or fluently. So language disorders occur when a patient has trouble understanding others. So that's receptive. They can't understand what somebody's saying to them. They're receiving that. Or sharing thoughts, ideas, or feelings. So expressive language is when they try to share their thoughts or ideas and feelings and have some type of barrier to that. Language disorders can be spoken or written and may involve the form, context, or use of language in functional and socially appropriate ways. So we're talking about the phonology, the semantics, the pragmatics, really breaking down what is language and how can we continue to communicate. There are ways that people use communication devices. We have text message, we have a lot of different things that have really helped that specific group of individuals who have difficulty with communicating. We think a lot of it being voice and speech and loud, and there's so many different ways we can communicate. And even in children, there's ways that they can communicate. There's ways that they use certain pointing, certain just looks at their parents that some children should be doing at a certain age. So they really work a lot with pediatric patients, but this can also happen after a stroke. You may have difficulty with speaking. You may have difficulty with problem solving. That's where speech and occupational therapy can overlap with some of these cognitive communication disorders. So organizing thoughts, paying attention, remembering, planning, problem solving. So as you're starting to see, there's some overlap between PT and OT, and then OT and speech, and then just all together collectively, we work to get that patient or that individual back into their just everyday life. That sometimes is the first and foremost thing we need to help people with. And then little by little, I mean, they may have all three disciplines, and then their walking's fine, but their cognition or their planning or their organization of thoughts maybe something that they still need work on. So then they may still have occupational therapy and speech therapy in that sense. So all three are working together to make sure that patient gets back to their new normal in a lot of cases. So we're going to talk a little bit about the clinical settings that we're within. So these are some of the most, I'd say, life-altering settings that we're in on this first page here. So acute inpatient rehab and subacute rehab. So acute, we do have all those clinicians, physical therapists, occupational therapists, and speech therapists in the acute setting, which is the hospital setting. There are three main areas of focus. So it's functional mobility that your therapist is going to help you with. So those are bed mobility, transfers, and ambulation. So that's the main thing we want to do in the hospital setting, is be able to get you up moving, be able to just get you to the next level. Some people in the hospital setting truly just can't even get out of bed. They need to make sure their medications are on board. They've got to make sure their blood pressure is appropriate. So sometimes we're working with a whole plethora of other individuals in the hospital setting. I may not be able to go into a room until I know they got their certain medications for blood pressure, because if I go in too soon, they're not going to be able to stand up with me. If they do stand up with me, they might zonk out. Their blood pressure might drop, and it's not an appropriate use of care. So it's very interdisciplinary within the acute care setting. That next level is inpatient rehab. So this is a physical admission to a rehab facility where the patient will live for a period of time and undergo intensive rehabilitation therapy. So the key word there is intensive rehabilitation therapy. So they're really working with therapists for a minimum of 3 hours a day, at least 5 times a week, to help regain their independence after a life-changing injury or illness. So these are the people that I was previously a banker. I was previously doing finance. I had some type of injury that took me to the point where I need intensive therapies to get back to that. A lot of times it has to do with some type of neuromuscular disorder like a stroke or a traumatic brain injury, gunshot wound, something like that could really take people from some of the highest levels of mobility and cognition to some of the lower levels, but there's still a lot of plasticity in that brain. So if we really focus on that specific individual and give them the most therapy, the most intensive therapy, they can get back to that new baseline. And that sounds like, well, why wouldn't you have everybody go through that? That sounds like something everybody should go through. There's different diagnoses, there's different prognoses that say, okay, this patient, if you did have, certain amount of movement, if you did have certain amount of brain function following a stroke, there is a higher likelihood that you'll be able to get to there. So that's why it is an interdisciplinary team decision in which type of setting you will fall into and be able to progress from. The last one on this page is subacute rehab. Subacute rehab is a lower level than acute rehab in terms of intensity. So we're still trying to get that patient some increased amount of therapy. They still have some ability or prognosis to get back to their baseline, but they can't really handle the intensity that inpatient rehab provides, that 3 hours a day, 5 times a week. This is a person that wouldn't be able to handle that, but they'd still benefit from the increase in therapy. And with both of those last settings that I spoke about, inpatient rehab and subacute rehab, you are physically in a facility. You live there. You are there so that you can get that consistency in therapy. So clinical settings continued. We also have therapists within the emergency department. At Lutheran General Hospital, we have a rotating shift of 5 physical therapists that are in our outpatient setting and in the emergency room. They collaborate with physicians, especially on musculoskeletal injuries. So for instance, somebody had a trip and fall, they need to use a walker, they need to use crutches. Our physical therapists can really work with them and open up the hospitalists and the physicians to more appropriate care, especially with COVID. And our EDs are swamped with people coming in with different types of illnesses related to COVID. We want to make sure our staff and our physicians are spending time with the patients that they absolutely need to be. For someone who tripped and fall needs to be able to walk, or somebody who's having vestibular or vertigo symptoms that we can treat right in the moment. That's why our physical therapists are in that setting. It's not something that's extremely common. In Illinois, Lutheran General Rehab for Advocate is the only Advocate site in Illinois that has PT in the ED. There are other hospital systems that are embracing this concept and putting physical therapists in the emergency department. But for Advocate in Illinois, Lutheran General was the first to do so. And then home health. So this is the patient that a physician recommends the benefits of home health therapy services following a surgery, illness, or injury. And because of the patient's inability to leave the home, they're getting these services at their house. That is really the biggest thing. The physician has to deem them homebound. And there's a lot of reasons why they would have to be, but it can't be because you just don't have somebody at home to help you. In those cases, social workers, case managers will work with the patient to make sure that there is a person to drive them to a more appropriate setting. Sometimes it's just kind of a bridge from the hospital to the outpatient setting. But for some patients, they truly are unable to leave their home and work within the confines of their home for their therapy services. And then the clinical setting of outpatient, this is the setting that I am the manager of. This is the setting that I have the most experience in. So I'm going to elaborate most on this. Outpatient tends to focus on helping patients restore function following an injury so they can get back to their normal activities. These patients are independent enough to receive these services while living in the home or the community. We are basically a clinic that they come to, they get their services and go back home. We give them a home exercise program. That's the biggest thing with outpatient therapy. The good ones will make sure that you know what to do when you leave the clinic. They'll make sure that you understand how to do this within your home. They'll make sure the exercises they're giving you even in the clinic can relate to stuff that you can do back to your home. Because I don't, again, want to be the expert. I don't want to be the person that says, you have to come here and I have to be able to tell you every single thing and you can't do anything without me. For a lot of these different exercises, I can give you cueing, I can give you hand placements, I can make sure that you're in the right position. But after a couple of minutes, our patients are smart enough to understand, okay, I get the concept of it. And we make sure to send them home with printed copies of saying, okay, this is what you need to do. Obviously, we don't expect you to know everything after one session. On average, we see people about once to twice a week for 6 to 8 weeks. But within that time, we're really trying to just push as much patient education to you as possible as the patient. We want to make sure that you have the understanding and how to help yourself moving forward. A lot of these things like a sprained knee or a back pain, they're reoccurring. It's not something you're going to just fix and it's going to be better for the rest of your life. Sometimes it does, but a lot of times it's something that might creep up on you every couple of years, every couple of months. Or if you play like in a certain sport and you know that, okay, at the beginning of the season, I have to prep with certain physical therapy. I have to do this. We make sure that you're ready for that each time around. So this is the most diverse setting in the sense that you can have people with a high level stroke, and there's physical therapy professionals on professional athletic teams like the Bears, the Bulls, the Sox. All of them have physical therapists on their staff that help with athletic trainers that do a lot of the different rehab planning for those teams. So some common diagnoses in the outpatient setting related to the shoulder. Some of these might look familiar. Some of your parents may have had these. Some of you may have had these. But rotator cuff tendinopathy, impingement, AC joint separation, dislocation. That's a picture of shoulder impingement right here. So what happens with shoulder impingement is we have a small muscle called the supraspinatus that fits in a very small space between the clavicle and the acromion process of the scapula. So basically your shoulder blade connecting to your collarbone. There's a very small space there, that one of the largest muscles of the rotator cuff. And it's a large muscle in the sense of length, not girth, attaches underneath there to your upper arm to be able to allow you to lift the arm, to pull it back, reach behind your head. A lot of times in that case, there's bursa and muscle and nerve within that area that just over time with poor posturing, decreased muscle strength, impaired motor planning can become impinged and cause pain or dysfunction or weakness. Some common diagnoses of the elbow: olecranon bursitis, lateral epicondylgia, medial epicondylgia, often known as tennis and golfer's elbow. You don't have to play tennis or golf to get either of those. Right here with the hammer is a picture of a gentleman with some pain on his lateral epicondylgia, also known as, again, tennis elbow. So essentially it's an overuse injury. This can be somebody who consistently hammers, consistently screws the screwdriver into the screw, and that consistent motion just kind of puts an emphasis on the muscles that are right in that area, and that overuse or that consistent use, if not strengthened appropriately, if not managed appropriately, can become inflamed or just irritated. And then some common diagnoses of the wrist or hand: carpal tunnel, de Quervain tenosynovitis, trigger finger. So I do have de Quervain syndrome kind of highlighted with that person holding the pencil. You can see there's some tendons that cross through a tendon sheath. Again, a lot of this has to do with overuse. That can be people who write a lot. That can be people who are on their phone a lot. That can be people, oftentimes it's called gamekeeper's thumb. So if you have a controller and you're consistently, doing the controls for a specific video game, that's a lot of time where that overuse injury can occur as well. And just oftentimes in our every single day lives, the things that we do just consistently put stress on the body. And if you're not consistently strong in those areas, if you're not consistently conscious of what you're doing, over time that can become painful or weakened. So some common diagnoses at the hip: IT band syndrome, hip flexor strain, hip dysplasia. So you can see this gymnast here. She's got her hip over her head and pointed. Some of these things can stretch. So especially that leg that's over her head there, that's pulling the flexor muscles. The more that she stretches into that without doing the appropriate stretching and strengthening can cause additional pain or weakness in that region. And you don't have to be a gymnast to get any of these, or any type of a hip flexor strain. It can happen to any and everybody, and you could feel it walking up the steps. For the knee, you can have a meniscus tear, ACL, MCL, LCL, PCL sprain, patellar subluxation. So I have a picture of this Alabama wide receiver. He was in actually the college football final against Georgia, and this is a gentleman who was running, and very similar to how most ACL tears occur, He was not touched whatsoever. It's usually a non-contact injury. It is one of the stabilizing muscles in the knee, and he was making a cut to get away from a defender and tore his ACL. Ankle and foot common diagnoses: ATFL sprain, or the common high ankle sprain, plantar fasciitis, talocrural hypomobility. You see a lot of ATFL sprains or high ankle sprains in basketball players, soccer players, where you're consistently shifting, moving positions. This is Kevin Durant clutching at his high ankle there. I'm sure he's had his fair share of high ankle sprains throughout his career. And he is back playing with the New York Nets. So I wanted to stop there and just ask any questions. I know we have a couple participants on. So Georgia, Chris, any questions about anything we've talked about so far? Magda, anything? Okay, it looks like everyone's still on mute, so I'm going to assume there's no questions there. Magda, do you have anything? Yes, you're saying, hold on 1 second.
Patrick, I think because Magda's recording. Are you
I have an
Gotcha.
issue. I think I'm good. I'm so sorry. Something my mouse and keypad froze, so I wasn't able to unmute myself.
Oh, no worries.
Little technical
no worries.
difficulties, but this is great so far. So Patrick, when I'm listening to you, it makes me want to ask if you guys have courses for people how to stay healthy so we don't get hurt. Because a lot of these things you talk about is overuse or improper use. So
Yeah.
yeah, besides,
I mean, there's different things we do within the community for sure. I mean, it's been less just because of COVID, but I'd say consistently we're doing different type of community events, things to just give more information, especially I mean, all of us as humans, we do things over and over. And the point is, you're not going to get injured necessarily just because you do some things over and over. But the point is, like, you can have two people doing the exact same thing, and you could have one person that has pain, one person that doesn't. I'd say overall exercise is important. The recommendations are moderate exercise, at least, I believe it's 3 to 4 times a week. Moderate exercise is considered something that brings your heart rate over 100 beats per minute. So I would say consistent exercise. There's so many different things that you can be doing, whether it's playing in a sport, whether it's going to the gym, whether it is Tai Chi, aerobic, swimming, whether it's, I mean, it can literally be anything, but get out, exercise, move. The more that you do that, the less inclined that you are to have something kind of bring you all the way back down from some type of an injury. It's inevitable that some people will have injuries, some people will have pain. There's probably not just a common, like, oh, if you do this, you'll never have an injury, you'll never have pain. But I would say just get out, move, exercise. It doesn't have to look like somebody in a gym, lifting weights. It can look like however you want to do it. So I ask people to self-reflect on what would help you be most consistent. For me, I like to play men's league hockey. I play in men's league softball. I mean, there's different things that I do to just keep myself active. I like to run. So I like to switch it up just to keep myself just at least doing something on a consistent basis.
Perfect, thank you. So physical therapists don't only treat folks, but also help with prevention and recommendations. So that's
yeah,
great
absolutely. And I mean, we even get injured ourselves. I mean, we're humans as well. We know all the things to help us. We know all the things to make us better. But there's some times that I'm sitting too much, or in the winter that I'm not getting up as much and active. So, I mean, just continuously being just good stewards of movement and exercise. Yes, we're always here from preventative measures to after people get injured.
Perfect. Thank you.
All right. Well, I'm going to keep moving forward unless there's any other questions. Feel free to unmute yourself in that sense. We're going to talk about some clinical jobs and required education. So physical therapist, which I am, you'll need a postdoctorate physical therapy degree. So it is a postgraduate doctor of physical therapy degree, or DPT. So most people need 4 years of undergraduate work. It can be in a lot of different things. It doesn't necessarily have to be like kinesiology or health sciences. In my DPT program, we had someone who majored and had his bachelor's degree in theater, and he worked on Broadway and he did a lot of different shows. He wanted a career change. It was a lot more challenging for him. He had to take some prerequisites, had to take a lot more science classes just in his own time to be able to apply into the graduate degree. But I'd say the easiest course of action is trying to do some type of biology major, some type of kinesiology, health sciences, something where you're going to take anatomy, physiology, biology, are going to be a lot of the prerequisites for a doctor of physical therapy degree, and most of these degrees in general. For a physical therapy assistant, so that is a professional that works within a rehab setting, that they are not able to do evaluations, but they are able to do the treatments. So a physical therapist can do the evaluation of a patient, say, okay, this is our plan of care moving forward, and the physical therapy assistant can take them through the interventions. So there are some decreased things that an assistant can do, but still absolutely needed, absolutely warranted expert within our field. They need an associate's degree. Again, there's still some specific prerequisites that are required, but it is a 2-year associate degree, or typically 2 years, sometimes less than 2 years, just based on accelerated programs. Occupational therapist. So there are 2 different occupational therapy degrees that are widely accepted at this time, and that is the postgraduate doctor of occupational therapy degree and the postgraduate master of occupational therapy degree. So similar to physical therapy, there are occupational therapists are moving more into the doctorate degree. I would say physical therapy has been on a track that is a little bit more advanced than occupational therapy. So at this point, I think every single school is a doctor of physical therapy accredited school. For instance, I had a roommate who was actually in a master of physical therapy program. So that's what occupational therapy is going through at this point. They're transitioning from master to doctorate level degrees, but still extremely widely accepted are both. And then similar to the physical therapy assistant, there's the occupational therapy assistant. Same thing, unable to do evaluations, but absolutely part of the team and absolutely warranted to do the follow-up treatments, the interventions, and following that plan of care. And then there's the speech and language pathologist. So again, this is a postgraduate degree with a Master of Science in Speech and Language Pathology. This is a master degree. All of these, like I said, require graduation from an accredited therapy program. So that therapy program has had to go through accreditation to be able to graduate you with this specific degree. And then the last piece of this is you have to pass your state licensing boards. Usually you have to pass each state licensing board. So if I went from Illinois to Colorado, I'd have to retake that test or do some type of accreditation process to make sure that it switches over. So with all of these, you can get that degree, but you also have to keep your license up to date. With physical therapy, occupational therapy, with all of these, they have to be done on a consistent basis. So every 2 years, I have to renew my physical therapy degree. I have to have a certain amount of, my license for physical therapy. You have to have a certain amount of continuing education. There's a plethora of things that you have to do to be able to keep up with your licensing. Continuing, so like I said, for PT, OT, and speech, general education requirements have increased emphasis in the study of anatomy and physiology. And anatomy is the identification and description of the human body and structure, being able to say that is the olecranon process, that is the humerus, that is the glenohumeral joint. And then physiology is the functions and activities of life and living matter, such as organs, tissues, and cells. So the ability for my body to, action potentials to shoot off, for my muscle to contract in a certain way, having that background in biology, kinesiology, is going to be very helpful in getting into these professions, can be very helpful in getting into a postgraduate physical therapy, occupational therapy, or speech program. And then the non-clinical jobs. We talked mainly about clinical positions within rehabilitation, but that's only half of our team. The other half is these non-clinical team members. I often say they're the most important team members. They keep the patients coming in and allowing us, for people to, as clinicians, for us to actually have a full caseload, be able to help people. They're the line between the patient and the clinic. So this is our secretary or patient service representative. They're responsible for patient-facing services relating to scheduling recurrent appointments, patient engagement. This is the first person somebody sees in our department. It's the first person they're interacting with on the phone. It's the person they're saying, okay, my therapist said I need one appointment for the next 6 weeks. I need one time a week for the next 6 weeks. Can you schedule me? So they are extremely vital to everything they're doing. They make sure that we have patients on a daily basis. They make sure that patients can be seen by our clinicians. Kind of an offset of that is some of our front desk staff and secretaries do insurance verification. So they're responsible for a lot of the business end of it, ensuring active insurance, that we're in network with a certain coverage of benefits. As people go through the selection of their insurance benefits in a given year, they opt into certain things. So what we have to make sure is that we are in network with you, that you do have physical therapy services, that you do have occupational therapy services, if that's what we're being seen for. And if you have a copay, that we make you aware of that as much as possible. So again, very important to the business aspect and just the finances of the patients as well. And then we have our rehab techs or aides. Sometimes they're the technician there or the aide, just depending on where you do this, but they're responsible for stocking and ordering equipment, supplies, switching over patient rooms, enhance infection prevention throughout the clinic, like wiping down tables, switching out the pillowcases, making sure that the lobbies are clean. And especially with COVID, we have increased presence of these rehab aides and techs. So most of these positions, specifically like insurance verification, secretary, you can get different types of certifications throughout, just depending on where you do this, whether it's in rehabilitation, whether it's in a physician office. There's different certifications that are available, but most of these specific non-clinical jobs, there's not a prerequisite of you have to have a bachelor's degree or you have to have a master's degree. This is something that you could potentially go into after high school, or you could go into after college without a certain degree. And that's not to say that they don't have a high level of expertise. Most of these people understand the medical terminology. They understand exactly what you say if you say you have a meniscus tear. So these are extremely educated team members. They are the lifeblood and lifeline of everything that we do within our outpatient clinics and throughout all of our disciplines and settings. So job statistics between 2020 and 2030, and this is based on statistics from the U.S. Bureau of Labor Statistics, the need for professionals in this field will increase between 17% and 29%, much faster than average. The median pay for therapists, that kind of combines every one of them, is $81,000 to $91,000. Therapy aides and assistants between $50,000 and $61,000. And then it says what type of work environments do physical therapists work in. It looks like offices, hospitals, home health, self-employed, nursing, residential care facilities. So there's a lot of different settings, and we went through a lot of those settings that we work in as physical therapists, occupational therapists, and speech therapists. We are growing a lot, especially in Advocate Aurora Health. We are growing out of this pandemic, whereas some different businesses or some different sectors of healthcare have maybe shrunken or decreased their bottom line. We continue to grow out of it. A lot of people strayed away from some of their medical professionals during the height of the pandemic, but now they're coming back in droves. So many people are looking for services. They've put it off a year potentially. They've put it off 2 years potentially. For some of these positions, just at Advocate Aurora Health, we have certain bonuses that are being applied because we have such a need for increased therapists. We have such a need for front desk staff, aides. So that just shows me that we're moving in a positive direction with a lot of these clinical and non-clinical positions, especially at Advocate Aurora Health. So my perspective, what brought me to this healthcare setting, what brought me to be a physical therapist, why did I want to do it? My interests were fascination with sports, medicine, being a part of a team. Played a lot of sports in high school, included soccer, ice hockey, cross country, baseball. Grew up playing football. In college, I played a little lacrosse just for fun. I just love sports, love watching sports, love the Chicago sports teams that I root for. I knew I probably wasn't great enough to play sports. I knew I was smart enough to probably go into some type of medical field. So that's kind of what I pushed myself towards. How can I still be involved with sports, do something with medicine or rehab? So that really, I don't have the story of, okay, I fell, broke my leg, went through months and months of rehab, and that's how I got here. Is really a fascination with still being a part of a team, being a part of sports, being a part of medicine. I also want to have a fulfilling job that helped people. I remained active. Didn't want to necessarily sit behind a desk. Didn't want to necessarily, do paperwork, taxes. That wasn't really intriguing to me. So I want to have something to do every single day where I'd be on my feet, moving around, and mainly helping people. So I would say I knew that coming out of high school, but not everybody has to know that exactly what they want to do. I would encourage as many of our high school students or college students, just ask people to shadow, ask people in your life to shadow what they do. I have a brother who's in college right now, and he's shadowing my wife, and she works in a dental office. He shadowed me a couple times. He's just trying to get a taste of what he likes. So if this even sounds intriguing to you, I would just say, ask your relatives, ask your friends parents, like, is there something that I can do? Can I show up to work with you? Can I spend an hour or two at your work? Can you just talk to me about what you do for your job? I would really encourage everyone to do that, because not everyone's like me that kind of thinks they know what they want to do. And some of us think we know what we want to do and get to college or take certain courses or trades and decide we want to do something else. So give yourself that experience, get out there, try to see what it is that gives you that drive, that purpose. So because I had that purpose and that drive, I went into get my bachelor's degree at Northern Illinois University in health sciences. So it took a lot of, again, biologies, anatomy, physiology, just things really to potentially be a physical therapist or get into physical therapy school at some point. I did do my postgraduate training at University of Illinois at Chicago for my DPT degree. Loved it there. I can't speak more highly of some of the programs we have just in the Chicagoland area. I mean, if you look at rankings and different things, UIC, Northwestern are up there in the rankings. And again, that doesn't mean everything. At the end of the day, you got to work your tail off. You got to learn what you need to do, and you got to pass your licensing. You got to pass your boards to be able to actually treat. So then my work experience, it was my second job out of school, where I ended up at Advocate Trinity Hospital. So it's a sister site on the southeast side of Chicago that is in network, or not in network, but a sister site of Lutheran General, a part of the Advocate hospital system. I started as an inpatient therapist, so in the acute care setting, hospital setting, did that for about 6 months. until I transitioned into the outpatient setting. And that's where my passion really lied. A couple of years later, became the outpatient coordinator for clinical services, and then the supervisor. It was recently I became the manager at Advocate Lutheran General Hospital, where we have 3 clinics. So we have a clinic at Advocate Lutheran General Hospital in our Parkside building. We also have a neurological clinic for our services in Des Plaines, and that's on Church and Potter. And then we have our 3rd clinic. It's in Niles on Oakton and Milwaukee. So, I mean, it really worked out for me in the sense that I knew what I wanted to do. I knew what I had a passion for. But as I told you that story, I mean, there was people from all walks of life in my DPT program. There were people, like I said, working on Broadway. There was people working for MTV. There were people who had a first career in real estate. So you don't have to know what you want to do right this second. You don't have to say, I'm just going to focus on this and I'm going to be a physical therapist immediately. I would just really encourage as many of our students just to get out there, try to get internships, try to get just shadowing experiences, talk to people about what they do, see if that intrigues you, go on site with them if possible. And this is my story. So we do have 2 team members, Heidi and Sina. I'm going to just ask if, before we get to them, if there's any questions about the clinical jobs that are within rehabilitation, any of the non-clinical jobs, my perspective, or any type of the job statistics. Any questions with that?
So Patrick, I do have a couple of questions. So my first question is about your education. How many years did it take you?
So, I mean, typical undergrad degree takes about 4 years to get your bachelor's. Like I said, if you get your bachelor's or your undergrad in something totally irrelevant to physical therapy, you will have to probably take some gen eds related to biology, anatomy, physiology, psychology, which can take another 1 to 2 years after that, depending on what you do. There are some people that finish their bachelor's degree in 2-3 years. But most of the time it's going to take 4 years to get that bachelor's degree. And then most doctor of physical therapy programs are 3 years. Most occupational therapy programs are 3 years. Most associate programs are 2 years. Something like at Marquette University, they have an expedited program where they actually admit people into the physical therapy program when they're applying into schools. So that's a 6-year program because they can expedite everything. I'm sure there's a couple of those out there, but I know Marquette for sure is a 6-year doctor of physical therapy program, but you have to be accepted as a freshman into that program. And I believe you do 3 years of undergrad and then 3 years of your postgraduate work.
Perfect. How about any internships, practicum, things like that that you have to have, you know, with hands-on experience before you're able to go on your own and officially graduate the program?
Yeah,
Your
so
exam?
each discipline has like requirements. So for instance, for physical therapy, there's a specific entry admission that you have to complete. It will tell you that certain schools will ask for, okay, you have to have X amount of hours. It will break it down for you when you do that. I would say in general, it is good to have that experience. If for instance, the physical therapy program that you're applying into, if they do have requirements or if they do have an interview process, your ability to say, I can speak to this more eloquently, or I understand what I'm getting myself into, could be a positive. But it's not everything. It's not, I mean, just because you may have worked as a tech or an aide or had volunteer services or had some type of shadowing experience in a physical therapy clinic doesn't mean that they're going to take you over somebody that didn't. But when you do go through that application process, each school has exactly what you need to have. And I could say for yourself, I would do it. For yourself, I would shadow. For yourself, I would try to get some internship to see if this is right for you. You don't want to find out 2 years into your your Doctor of Physical Therapy program or your Master's of Occupational Therapy program, that this isn't for you. That's a lot of time, energy, effort, and money that you're spending. So for your own peace of mind, for your own sake, I would try to get those experiences. However, it's not every program's requirement for you to do so.
Sure. How about once you are in school, in the program, what type of exposure do you get in a clinical setting? Do you get to pick if you are in a hospital or a standalone outpatient clinic? How does that work?
Yeah, there's usually rotations, and it varies school to school and discipline to discipline. Whether it's speech, occupational, or physical therapy, there is some type of field work or some type of clinical internship that's required to pass and graduate. At UIC, at the moment in time that I went there, we were put into different experiences, and I was very thankful for that. I was in the acute care side for a hospital setting. I was in the subacute rehab at a manor care for some of that rehabilitation setting. I was at UIC's outpatient pavilion for my outpatient clinical. So it was nice to get a taste of all of them. I think it made me realize which setting I wanted to be in most, but it also allowed me to be a little more flexible coming out of school. I was able to go into a couple of different settings, and even in one setting, you could definitely flex into other settings in your job. I mean, as an outpatient therapist, I have opportunities to work in an acute care setting to make some extra money here and there to help out, or just for a variety of reasons. I was thankful for that experience. But if you know what you want to go into, it's also not bad to try to set up all of your experiences, if your school allows it, in that setting. If you know you want to be an outpatient therapist, then if 2 of your clinicals or 3 of your clinicals are in that specific setting, you're going to be really ready to come in and treat outpatient patients. So I would say there's been more of a blend of schools allowing you to go for what you think your passion is for. But again, I'm really happy that at that point in time when I went to UIC, we kind of got pushed into these different settings. Most schools have local affiliations, depending on how many students there are, depending on what first choices, you may have to travel. I had some of my friends have to travel to the Cincinnati area or Indianapolis area, but they try to set as many of the students within the region as possible.
Sure. So Patrick, you mentioned travel for rotations, but how about being a traveling PT or to your speech? We are hearing that nurses are doing that. Is it something that is also happening in their rehab services?
Yeah, I had a good friend. She's actually married to a physical therapist as well, and she's a physical therapist, but they did do travel PT for a couple of years. They've settled down now. They have a child, but for the first couple of years out of school, they traveled. They were in Hawaii. They were in Oregon, Colorado. Like, they were able to do that, and you have to be the right person to do it. For me, I don't like being able to bounce around. I like kind of having one position, sticking to it, and kind of digging my heels in and planning my routes. But for them, I mean, that's totally their personality. There's different pay with it. There's good and bad. There's definitely more pay with it, but you don't necessarily get to choose the exact setting. You may say, this is really important to me to be in Portland, Oregon. Put me wherever needs somebody. So they may pick the setting for you, but you may say, I want to work within this region in outpatient. If it's an outpatient setting, that's more important to me. So there's a lot. They definitely have travel physical therapy. They have different types of occupational therapy that travels as well. And I'm not 100% certain on speech, but I'm sure they do. So it's definitely something you can do. You just have to have the right personality. It has to be right for you to do.
Sure. And is your degree, so like for nursing, you have to be licensed in a specific state. Is it the same for a physical therapist?
Yes, it's the same for a physical therapist, occupational therapist, and speech therapist. If you did do the traveling, they would work with you to make sure that you got those specific license. And in a lot of those, you have to take the test again and pass that test for that specific state. Some of the states have, I forget exactly the word I'm thinking of, but like co-residency. If you pass in this state, you're able to work in this state that neighbors it as well. So there definitely is that within rehabilitation as well.
Okay, perfect. So my one more question has to do with treating patients. So on average, how many patients do you see a day as a physical therapist?
So it will vary from setting to setting. We definitely have productivity standards. Some are more specific than others. I'd say in our outpatient setting, in an 8-hour day, our productivity standard is to see 80% of your workday of patients, which comes out to about 9 patients a day in an 8-hour day. This is in a hospital outpatient department versus some of those private clinics. You may have to see a patient every 30 minutes. You may have overlapping. You may have different reasons where you see closer to 15 patients a day. In the acute care side, everybody you kind of split it up between the team and say, okay, you have X amount of patients. We have to spread this throughout the department. And if one of my patients, for some reason, I can't see them, or they're at a test, or another service is seeing them because I'm in the hospital, I might be the person picking up a new evaluation or something that comes in during that day. So it fluctuates. It definitely fluctuates. There is a standard of productivity that most of our team members are held to, and it's a year-to-date productivity. It's not something like every day you have to be able to see X amount of patients, because there's ebbs and flows. Specifically working in the Midwest, it's going to be lighter during January and February, but in June, July, August, most people are going to show up for their appointments. So, I mean, if you go every day, I'd say it's fair that most times you're going to see somewhere between 8 to 10 patients in a given day. But that will definitely vary on the setting.
So a session per patient lengthwise, it may vary, right? Based on what the situation is and if it's a new evaluation. Mm-hmm.
Right. And at Advocate Aurora Health in our outpatient department, we have 45 minutes for evaluations, 45 minutes for all follow-up treatments, and that's 1-to-1. I've worked for different systems. I've worked for different private practices where I had 2 people at once. I had within an hour 4 people. It just really depends in which setting you work in.
Okay, perfect. Any other questions? Anybody else?
Okay. So I do think, for sake of time, and just knowing we have not a huge amount of audience right now, do you want me to share the team member stories? Is that something we can just share the YouTube link for? Do you want me to actually share it on this presentation?
Yeah, we can share a link to those. So okay. The flyer has our link, and I'm also going to add it in the chat box right now so that the folks who are here with us can just go onto our YouTube channel. I'm going to put it in there right now, and it's also on the slides, but I'll put in the chat box. So
yeah, and what that is, it's 2 of our team members. It's Heidi Barnett and Sina Matthew, and both of them are physical therapists with us at Advocate Lutheran General, and both of them have amazing stories. Like, I don't have as cool of a story, so I really encourage people to listen to them. Both of them started as, Heidi started as just a volunteer and moved into a rehab aide, and then went to physical therapy school. It's very cool to see the evolution, and that's what happens a lot of the times with our volunteers or just students that have been on site. They spark an interest. They're like, this is what I want to do. And we've hired a lot of those people in different roles within rehabilitation, whether it's physical therapy, occupational therapy, whether it's they've had their clinical internship in their postgraduate school here. There's just a lot of examples of people who have started, I guess you would say, at the lower end of the totem pole and kind of worked their way up to the top. And it's a lot of hard work to get there. So, I'm very proud of those stories. So yeah, please watch them. It's Sina and Heidi within this YouTube link here. And I alluded to, we have volunteers that are coming on site. Currently, we have volunteers at some of our Oak Mill and Parkside locations who have been coming and for years have always had a good relationship with the high school systems within the region. but we continue to need volunteers. We continue to want to be able to provide that educational experience. It really is a two-way avenue. You get that educational experience in being a volunteer, you get to talk to those professionals, you get to immerse yourself in that clinic. But we also need help. I mean, we need help changing over tables. We need help, when pillowcases have to get changed or equipment needs to be stocked. So it really is a two-way street. We try to give you as much of an observational experience as possible. We have so many clinicians that are more than happy to share their time, to introduce you to patients, to tell you what they're doing, why they're doing it. And like I said, I think for yourself, you owe it to you if you think this is something you want to do. Don't do it because the school makes you do it. Don't do it because you think you want to impress on your resume. Do it to make sure it's the right thing for you. I think so often people are like, I just want a good job. I want to make a lot of money. Sure, you make a good amount of money, you make a good living. It's extremely rewarding, but make sure it's right for you. Money will come. You'll make money doing anything in life. Just make sure this is something you want to do. And, you can do that through some volunteering services. Again, it's really like a really good way to shadow and get that experience that you can put on your resume, to put on your admissions into any of these schools.
Perfect. And then if anybody's interested in volunteering, there's also a link in the presentation, and the YouTube channel also has a video clip by one of our outpatient physical therapy volunteers talking about her experience at one of our facilities. So also a great way to hear firsthand about what the impressions are from a volunteer, if you were to consider that.
Great. And I know, Magda also shared that in the chat as well. So that is the end of the presentation at this time. So just wanted to open up for any final questions or anything else that I'd be able to share. Thank you for having me on. It's truly a pleasure to be able to just hopefully spark some interest in rehabilitation, and hopefully, we can have a lot of the students that listen to this or the people that are on here today, at least have that thought, is this something that's right for me? And we can provide some of that opportunity for you here at Lutheran General.
Perfect. Thank you so very much. I'm going to stop the recording. Christopher, thank you for joining us. And Georgia, thank you for being here.
Yeah, thank you so much for this extra information.
Yeah,
Christopher, any specific questions or anything that I can provide?
Yeah, just something I was wondering. I noticed a lot of I just like you, I really like sports. And I noticed a lot of professional sports teams have physical therapists on their, I don't know, you'd call it salary. Is there any way they got there specifically? Yeah, I was just wondering that.
Yeah, I think with a lot of things, it's being in the right place at the right time. Some sports teams have affiliations. Like for instance, Advocate has affiliations with different sports teams, with the Bears, with the Cubs, the Bulls. So we've had opportunities to work with some of their representatives in the past. Or I know, and I'm not trying to shout out a different hospital system or anything like that, but Athletico has had a lot of different partnerships. So sometimes it's just being in the right place at the right time. I have a buddy who works for a really sports specific physical therapy clinic. It's a privately owned clinic in the West Loop, just happens to be steps away from the United Center. They get a lot of Bulls players. They get a lot of Bears players. I'm sure if you talk to someone who has that specific position, it's just a lot of good luck. There's a heck of a lot less of those positions out there than hospital positions and clinic positions. The likelihood of getting that position would be a lot lower. But I think it's just a lot of luck. I think it's a lot of just time, energy, effort that person might have spent. And you could have done everything by the book. You could have said okay, I worked for the places that they have affiliations with. It doesn't always mean you're going to become that main therapist. So I guess that's a long answer to it just depends.
Yeah, thank you.
Yeah, thanks, Christopher.
good question. Alrighty.
Well, I do appreciate everyone being on. I appreciate being able to tell my story and to
Thank
brag a little
you.
bit about Rehabilitation Services. So thank you.
Thank you.
Thank you.